illness, inflammation, inflammatory disorders, and woe dealing. So let's begin with introduction. So, in inflammation, this allows inflammatory cells, plasma proteins like complement proteins, and fluid to exit the blood vessels and enter the interstitial space. And it is divided into acute and chronic forms of inflammation. So, what is acute inflammation? Well, here's some basic principles of acute inflammation. It is characterized by the presence of edema and neutrophils in the tissue. Okay? And it arises in response to infection. So, that is to eliminate the pathogen, or tissue necrosis to clear the necrotic debris. And it has immediate response with limited specificity. This is known as innate immunity. So, once again, characterize the presence of edema and neutrophils, and then it arises in response to infection or tissue necrosis. Those are two key things. So let's talk about mediators of acute inflammation. So we have toll-like receptors, or TLRs. These present on the cells of the innate immune system, like the macrophages and dendritic cells, and that they are activated by pathogen-associated molecular patterns that are commonly shared by the microbes themselves. So, for example, the CD14, which is a co-receptor on the toll-like receptor 4 that are found on the macrophages, will recognize the lipopolysaccharide, which is a pathogen-associated molecular pattern on the outer membrane of the gram-negative bacteria. So, that's one example. And then the toll-like receptor activation results in the upregulation of NF-kappa B, or nuclear factor kappa B, which is a nuclear transcription factor that activates the immune response genes, leading to the production of multiple immune mediators. And the toll-like receptors are also present on the cells of adaptive immunity, such as lymphocytes, and hence they play an important role in mediating chronic inflammation. Now, let's talk about arachidonic acid metabolites. So the arachidonic acid is released from the phospholipid cell membrane by the enzyme phospholipase A2, and then acted upon by the cyclooxygenase or 5-lipoxygenase. By the way, AA stands for arachidonic acid, but just remember that they're released from phospholipid cell membrane by phospholipase A2 before being acted upon by the cyclooxygenase or 5-lipoxygenase. The cyclooxygenase produces the prostaglandins, or PG, the prostaglandin I2, the prostaglandin D2, and the prostaglandin E2 mediate the vasodilation and increased vascular permeability. Then again, prostaglandin I2, prostaglandin D2, and prostaglandin E2 mediate vasodilation and increased vascular permeability. And then the prostaglandin E2 will also mediate the pain and a fever. produces the leukotrienes. So the leukotriene B4 or LTB4 attracts and activates the neutrophils. And the leukotriene C4, leukotriene D4, and leukotriene E4 will mediate the vasoconstriction, bronchospasm, and increase the vascular permeability. So, leukotriene E4, D4, and C4, they're slow-reacting substances of anaphylaxis. So again, leukotriene B4 attracts and activates neutrophils, while C4, D4, and E4 mediate vasoconstriction, bronchospasm, and increase the vascular permeability. And then we have mast cells. So these are widely distributed throughout the connective tissue in our body. And the mast cells are activated by the tissue trauma or complement proteins C3A and C5A, or cross-linking of cell surface immunoglobulin E by the antigen. So again, mast cells activated by tissue trauma, the complement proteins C3A and C5A, or the cross-linkage of the cell surface IgE by the antigen. And they're widely distributed throughout the connective tissue. And then we have immediate response that involves the release of preformed histamine granules from the mast cells. And these histamine granules will mediate the vasodilation of the arterioles and increase the vascular permeability. And then there's going to be delayed response that involves the production of arachidonic acid metabolites, particularly the leukotrienes. So what's important to remember is mast cells that are triggered will involve immediate response involving the release of preformed histamine granules, which mediate vasodilation of arterioles and increase vascular permeability. And they can also be involved in delayed response involving the production of arachidonic acid metabolites, particularly leukotrienes. Then we have the complement proteins. So these are pro-inflammatory serum proteins that quote-unquote complement the inflammation, and they circulate as inactive precursors. So the way they are activated occurs through the following mechanism. First, we have the classical pathway, where the C1 binds to the immunoglobulin G, or the immunoglobulin M, that is bound to the antigen. We also have the alternative pathway, where microbial products happen to directly activate the complement protein. And then we have the mannose binding lectin pathway, or the MBL pathway, where the mannose binding lectin binds to the mannose on the microorganisms and thereby activates the complement protein. And then all pathways will result in the production of the C3 convertase. So the C3 convertase enzyme mediates the conversion of your C3 complement protein to your C3A complement protein, and also the C3B complement protein. And so this will in turn produce the C5 convertase, and then the C5 convertase will be responsible for mediating the conversion of C5 protein into the C5A protein, along with the C5B protein, as shown over here. C5 being converted to either C result in the histamine-mediated vasodilation and increased vascular permeability, which we talked about earlier. The C5a is chemotactic for the neutrophils, and then the C3b is an opsonin for the phagocytosis of a foreign organism. Again, C5a is chemotactic for neutrophils in addition to being an anaphylatoxin, while C3b is an opsonin for phagocytosis. Then we have membrane attack complex. This will lyse the microbes by creating a hole in the cell membrane. So, the creation of a hole in the cell membrane in order to lyse the microbes is a key feature of the membrane attack complex, which again is a complex of C5b with C6 or C9 complement proteins. Let me go turn the lights to make sure. Alright. Hopefully you can see the words more clearly now. And then we have the H-man factor, or factor 12. So the H-man factor is an inactive pro-inflammatory protein that is produced in the liver. And they are activated upon exposure to subendothelial or tissue collagen. And then they in turn activate several things: the coagulation and fibrinolytic systems, the complement proteins, and then the kinin system. And then the kinin will cleave the high molecular weight kininogen, or HMWK, to bradykinin, which then mediates vasodilation and increased vascular permeability, thus having similar function to histamine. And the bradykinin will also mediate pain as well. So that is the H-man factor, also known as factor 12. And remember, it isn't active initially, but it is pro-inflammatory protein produced in the liver. And in order for it to be activated, it must be exposed to some endothelial or tissue collagen. This will in turn help to activate the coagulation and fibrinolytic systems, complement proteins, and the kinin system. And remember that kinin will be responsible for cleaving the high molecular weight kininogen into bradykinin, and that the bradykinin will mediate vasodilation and increase the vascular permeability as well as pain. Now that we covered the different agents for inflammation, let's now talk about the cardinal signs of inflammation. So what you'll look for are redness and warmth. Redness, also known as rubor, and warmth, also known as calor. The redness and warmth are due to the vasodilation, which results in an increased blood flow. This will occur through the relaxation of the arteriolar smooth muscle. And the key mediators of this are the histamine, prostaglandins, and bradykinin. So, for swelling, that is another cardinal sign of inflammation. And this is also known as tumor. The swelling is due to the leakage of fluid from the postcapillary venules into the interstitial space, and it's known as exudate. Again, it's the postcapillary venules that are leaking the fluid into the interstitial space, and that is the main etiology of the swelling when it comes to inflammation. So the key mediators of this include histamine, which causes endothelial cell contraction and tissue damage, which will result in endothelial cell disruption. And then, of course, pain is another cardinal sign of inflammation. Pain is also known as dolor. And the main mediators of this are the bradykinin and the prostaglandin E2. These will both sensitize the sensory nerve endings. So again, it's redness and warmth, swelling and pain. Swelling is due to leakage of fluid from both scapulary venules. And mediators of swelling include histamine, which causes endothelial cell contraction, and then also tissue damage, resulting in endothelial cell disruption. So here's a quick histological sample of an acute inflammation with neutrophils, and then a chronic inflammation with lymphocytes and plasma cells. And then there's one more important cardinal sign of inflammation, and that is fever. So regarding fever, we have pyrogens from the lipopolysaccharide of bacteria. These pyrogens cause the macrophages to release the interleukin-1 and a tumor necrosis factor, also known as TNF, which will then increase the cyclooxygenase activity in the perivascular cells of the hypothalamus. And the increased prostaglandin E2 raises the temperature set point. So these are known as pyrogens. And a common source of pyrogens are the lipopolysaccharide from the bacteria. The pyrogens will cause macrophages to release interleukin-1 and tumor necrosis factor. And then we have neutrophil arrival and function as key mediator of inflammation. So this is very important to know because there are several steps. So step 1 is margination. This will involve vasodilation that slows blood flow in the postcapillary venules, and then cells will marginate from the center of the flow to the periphery of the blood flow. And then step 2 is rolling. So in this step, we have selectin speed bumps that are upregulated on the endothelial cells. So first we have P-selectin. This will be released from the Weevil-Pilati bodies, and this is mediated by the histamine. And then we have E-selectin. E as an elephant, so E-selectin is induced by the tumor necrosis factor and interleukin-1, which again is released by macrophages to mediate fever. But anyways, the E-selectin and the B-selectin will serve as speed bumps on the endothelial cells. And then the selectins, these selectins will bind to the sialo-Lewis 10 or axon leukocytes. And the interaction results in the rolling of leukocytes along the vessel wall. So leukocytes have sialo-Lewis 10 or X. And this interaction results in leukocytes along the vessel wall. And then we have step 3, which is adhesion. So cellular adhesion molecules like ICAM and VCAM are upregulated on the endothelium by the tumor necrosis factor and the interleukin-1. The integrins are also upregulated on the leukocytes by the C5a complement protein and the leukotriene B4. So the interaction between the cell adhesion molecules and the integrins results in the firm adhesion of leukocytes into the vessel wall, and then leukocyte adhesion to most commonly due to an autosomal recessive defect of the integrins, particularly at the CD18 subunit. Remember that integrins are upregulated on the leukocytes themselves by the C5a and the LTB4. So that's the leukocyte adhesion deficiency, or at least a common source of it. So when this happens, clinical features include delayed separation of the umbilical cord, increased circulating neutrophils due to the impaired adhesion of marginated pool of leukocytes, and then recurrent bacterial infections that lack the pus formation. And then we have step 4, which is transmigration and chemotaxis. So in this step, leukocytes will transmigrate across the endothelium of the postcapillary venules and move toward the chemical attractants. This is known as chemotaxis. And the neutrophils are attracted by bacterial products like interleukin 8, the C5a complement, or the neutrophils are attracted by bacterial products as well as the interleukin 8, the C5a complement protein, and the leukotriene B4. Then we have step 5, which is phagocytosis. So here, consumption of pathogens or necrotic tissue takes place. The phagocytosis is enhanced by opsonins, which involve the immunoglobulin G and the C3b complement protein. Because remember that earlier we talked about the C3b, shown over here, serving as a mediator of opsonin for phagocytosis. But anyways, just remember, phagocytosis is enhanced by opsonins like immunoglobulin G and the C3b complement protein. So as part of the phagocytosis mechanism, the pseudopods will extend from the leukocytes to form the phagosomes, which are internalized and merge with the lysosomes to produce phagolysosomes. Again, that's pseudopods extending from the leukocytes to form phagosomes, which are then internalized and merge with the lysosomes to produce phagolysosomes. We have this thing called Chidiac-Higashi syndrome, and that's where we have a protein trafficking defect. So the Chidiac-Higashi syndrome is a protein trafficking defect. It is also autosomal recessive inheritance, and it is characterized by impaired phagolysosome formation. So the clinical features of the Chidiac-Higashi syndrome include increased risk of pyogenic infections, neutropenia, that is due to the intramedullary death of the neutrophils, and then giant granules in leukocytes, that is due to the fusion of granules arising from the Golgi apparatus, and then also defective primary hemostasis, which is due to the abnormal dense granules in the platelets, and then albinism and peripheral neuropathy. So again, the main features of Chidiac-Higashi syndrome, which is due to neutrophil protein trafficking defect that results in impaired phagolysosome formation. The main features include increased risk of pyogenic infections, neutropenia, giant granules in leukocytes, defective primary hemostasis, albinism, and peripheral neuropathy. Then we have step 6, which which is the destruction of the phagocytosed material itself. So, this is where oxygen-dependent killing is the most effective mechanism for the destruction of the phagocytosed material. So the HOCl is generated by the oxidative burst in vagal lysosomes. And then once the HCl is generated, it will destroy the phagocytosed microbes. So the first step for this is that oxygen is converted into an oxygen radical by the NADPH oxidase. This is known as oxidative burst. Then this oxygen radical is converted into hydrogen peroxide by the superoxide dismutase, or SOD. And then the hydrogen peroxide is then converted into HOCl, or bleach, by the myeloperoxidase enzyme, or MPO. So bleach will be produced in the vagal lysosomes, and this will destroy the phagocytosed microbes. And bleach is produced first by conversion of oxygen into a radical by NADPH oxidase, then to hydrogen peroxide by superoxide dismutase, and then to bleach by myeloperoxidase. Okay, so continuing on the destruction of phagocytosed material, we have this disease called the chronic granulomatous disease, or CGD. The chronic granulomatous disease is characterized by poor oxygen-dependent killing. It is due to the NADPH oxidase defect, and this defect can be X-linked or autosomal recessive for inheritance. And a chronic granulomatous disease leads to the recurrent infection and granuloma formation with the catalase-positive organisms, particularly the Staphylococcus aureus, the Pseudomonas cepacia, the Serratia marcescens, the Nocardia, and the Aspergillus species. And these are the species that can trigger the recurrent infection and ultimately granuloma formation because they have the catalase enzyme. And so we also have the nitro-blue tetrazolium test that is used to screen for the chronic granulomatous disease. So in this case, the leukocytes are incubated with the NBT dye, which turns blue if NADPH oxidase can convert the oxygen into the oxygen-free radical. But it remains colorless if the NADPH oxidase is defective. And that's how you can identify leukocytes with defective NADPH oxidase that could then contribute to the chronic granulomatous disease. Then we have myeloperoxidase deficiency, and MPO deficiency, or myeloperoxidase deficiency, results in the defective conversion of hydrogen peroxide to bleach, or HOCl. This can lead to increased risk for candida infections. However, most patients are asymptomatic in such cases. The NBT is normal, and then the respiratory burst from O2 to H2O2 is intact. Then we have oxygen-independent killing, and it is less effective than oxygen-dependent killing, and it occurs enzymes present in leukocyte secondary granules. Again, the oxygen-independent killing is involving enzymes present in leukocyte secondary granules. So, for example, the lysozyme in the macrophages and the major basic protein in eosinophils. So the major basic protein in eosinophils and the lysozyme and macrophages are examples of enzymes present in leukocyte secondary granules, which involves oxygen-independent killing. And then step 7 is resolution. So neutrophils undergo apoptosis and disappear within 24 hours after resolution of the inflammatory stimulus. Again, resolution is when neutrophils finally undergo apoptosis and disappear within 24 hours after resolution of the inflammatory stimulus. So those are the 7 steps associated with neutrophil-mediated inflammatory response. Then we have macrophages. Macrophages predominate after neutrophils, and they peak 2 to 3 days after inflammation begins. So, macrophages are derived from monocytes in the blood. They arrive in tissue through the margination, rolling, adhesion, and transmigration sequence, similar to neutrophils. And they ingest organisms through phagocytosis, which is augmented by opsonins. And then they destroy phagocytosed material using enzymes like lysozyme and secondary granules. And again, secondary granules involves oxygen-independent killing. And then the macrophages also manage the next step of the inflammatory process. So the outcomes for this next step in the process include resolution and healing. So anti-inflammatory cytokines like interleukin-10 and TGF-beta are produced by the macrophages. There can also be continued acute inflammation. So this is marked by persistent pus formation. The interleukin-8 from macrophages will recruit additional neutrophils. There can be abscess formation. This is where acute inflammation is surrounded by fibrosis. The macrophages will mediate fibrosis through the fibrogenic growth factors and cytokines. Again, fibrosis will be mediated by macrophages through the fibrogenic growth factors and cytokines. And then, of course, we have chronic inflammation. This is where macrophages will present antigen to activate CD4 plus helper T cells, which will secrete cytokines that promote chronic inflammation. So these are the possible outcomes when macrophages are involved in inflammation. And remember that the macrophages will not only ingest organisms through phagocytosis, but also destroy the resulting phagocytosed